Thank you, Mr. President. We will begin this afternoon with severe disease, new treatments and preservation of fertility. And it's a pleasure for me to introduce the first speaker, Professor Isabelle Sermet-Gaudelus from Necker-Enfants Malades, who is chief of the Department of Pulmonology and who a very important experience in the treatment, management of cystic fibrosis. Thank you very much.
Thank you very much. Thank you very much to have invited me to speak at this very interesting meeting about multidisciplinary approach of care in pediatric diseases. And I must say first that you did not give me a very easy task, because speaking from cure to palliation in the field of cystic fibrosis is indeed speaking about the whole cure of cystic fibrosis. But what I intend to do in the next 20 minutes is to show you how in this disease the multidisciplinarity, the interaction between the fundamental research and the clinical approach have indeed paved the way forward to improve the daily life of the cystic fibrosis patients. And indeed, the person who first described this disease was Dorothy Anderson. She was a pathologist in New York at the Rainbow Hospital, at the Rainbow Baby Hospital. She was not a clinician at all, but she had to deal with very malnourished babies suffering of chronic diarrhea, and she first described cystic fibrosis of the pancreas. She also described with Schwarzman that those children had a very severe chronic bronchopathy and died from both respiratory failure and very severe malnutrition. And at this time, life expectancy was less than 2 years of age, and the only care that was proposed to this patient as in our hospital in Necker was to improve airway clearance and to make children breathe water steam and the spatial mist. But how you can see, life expectancy in these children has really improved very much. And now for a baby born in 2013 in US or in Europe, life expectancy is more than 45 years of age. In France, it's now over 50 years of age. And this is because we have now benefited of several treatments which are really the cornerstone of the therapy in the patient. And I want to speak first, I will only quote pancreatic extract introduction, which were introduced in the 50s, which have completely transformed nutritional status and amazingly improved survival in these patients. I want also to speak about airway clearance improvement by using these enzyme DNAs, which improves fluidification of the mucus. But very importantly, the increase in survival was also due to implementation of anti-Pseudomonas antibiotics, because chronic colonization with Pseudomonas is the cause of much of the morbidity and most of the mortality of this patient. And indeed, implementation of innate antibiotics, including tupamycin, has now proved very efficient in the eradication of Pseudomonas aeruginosa colonization in this patient. But the most recent progress have emerged both from the interaction between basic fundamental research and clinical teams, and they mainly are focused about the understanding of the very complex biogenesis of the CFTR protein, whose dysfunction or absence is the cause of the cystic fibrosis disease. CFTR, the cystic fibrosis transmembrane conductance regulator protein, involves a two-half protein which is composed of membrane-spanning domain, very tightly interacting with two nucleotide binding domain, linking ATP, engaging the channel here, and an additional domain which is regulatory domain, which is the two halves of the protein. And very importantly, CFTR biosynthesis synthesis involves a multi-level post-translational modification, including a very complex folding process in the endoplasmic reticulum, a glycosylation in the Golgi complex before reaching its native tertiary threshold and reaching the target localization, which is the apical membrane. So you see a very complex process for CFTR biosynthesis and maturation across the cell cytoplasm. The challenge now, after having better understood this biosynthesis, is to find therapies to correct CFTR for all CF-causing mutations. We know more than 2,000 mutations for this disease, and the challenge is to target all these mutations now to correct the basic step of the disease. And this is possible, or this can be endeavored, because we now have better understood the different classes of mutations. Very roughly, we can classify the mutations of CFTR in 3 classes. The first class is associated with a defective protein synthesis linked to nonsense mutation or friendshift mutations, but also for this 5th class, also a reduced amount of normal functional protein. The second class, which involves most of the mutations, is associated with a defective protein maturation, mainly due to a defective folding of the protein in the endoplasmic reticulum. These 2 classes of mutation are associated with the absence of CFTR or a very low amount at the apical membrane, whereas in this 3rd group of mutations, CFTR is located at the membrane but presents a defective function, either linked to a defect in activation, in the association of ATP to CFTR, or a defect in the connection through the channel of the ions which go across the channel. So this is associated with the presence of the protein, but a defective function. And I will first focus on this first class of protein, because that was the first step of the people working on CFTR to address a correction of this defective function. And indeed, what the basic sciences targeted was to potentiate, to increase the function of this protein. And they first focus on G551G mutation, which is associated with a defect in the activation of the protein, and namely an abolition in the ATP-dependent gating, because it inhibits linking of ATP to the protein. And they have implemented, after a lot of screening for huge amounts of molecules, for a compound whose name is Ivacaftor, which potentiates the channel open probability or gating of this very special mutation. And indeed, it maintains the protein in the open conformation and therefore increases chloride transport by the channel. And as shown in vitro study, increases airway surface liquid height above the bronchial epithelium. And indeed, after this in vitro preclinical studies, the company implemented phase 2 and phase 3 studies which show amazing results. First, this phase 3 study versus placebo showed that Ivacaftor has indeed a very profound impact on respiratory function. As you see here, this improvement by more than 10% in respiratory function, here FEV1, is obtained as early as 2 weeks of treatment and maintained over 2 years, and now 3 to 5 years of treatment. And as a very elegant proof of concept, the people who were treated under placebo, when they were enrolled in the open label study, joined the same improvement as the patients already treated with Ivacaftor. And indeed, this improvement is maintained, as I said, by more than 5 years of treatment. And this is, by now, the first and the only treatment which has a profound effect and such a maintained long-acting effect in the field of CF. Moreover, this improvement was associated with improvement in CFTR function, as we could get from in vitro study. And this was shown by normalization of chloride transport in sweat gland epithelium. This is the classical sweat test, which is a biomarker of CFTR function. As you can see here, the patients treated with Ivacaftor demonstrate a decrease in chloride concentration by more than 50 milliequivalent per liter and normalize their sweat test result, which obviously was not the case in the patients treated with placebo. And moreover, and I think most importantly, now we have first results from the open label study which follows the patients treated now with the marketed Ivacaftor drug. And what we now have as first results is a decrease in Pseudomonas aeruginosa culture rate in this group of patients, as early as 6 months and now also after 1 year of treatment. Whether this is due to simply decreased protein production, because these patients are better from the respiratory point of view, or whether this is a true eradication of Pseudomonas aeruginosa, we don't know yet. But if this is the last case, this is clearly an amazing progress and amazing improvement in survival of this patient, because as I said before, Pseudomonas aeruginosa chronicalization is most part of the mortality of these patients. So these results have to be confirmed, but already they are really a very interesting track and very interesting hope. Now I want to speak about the second group of mutations, which is a defect in the maturation process of the protein. The main mutation is delta F508 mutation, the deletion of the amino acid which is located in the 508 position. But now here the task is far more difficult as for the G551D mutation, because we have to address a very complex folding defect. Delta 508, or this amino acids, is located in a very hydrophobic group which interacts, it's located in the NBD1 domain, but interacts both with the membrane spanning domain and the nucleotide binding 2 domain. And therefore, the deletion of this single amino acid impacts on both nucleotide binding 1 folding, but also dimerization between the 2 nucleotide binding domains, which is absolutely mandatory to gate the channel, but also impairs the assembly between the nucleotide binding 1 domain and the second membrane spanning domain, therefore leading to impaired folding of the protein and targeting, therefore, the misfolding protein for degradation in the proteasome pathway. And therefore, to address this delta F508 defect, we have to deal with a multiplicity of molecular targets. And indeed, a number of labs are working across the world on this mutation. The first compound which has now reached the clinical development is Ivacaftor, VX809, and indeed, in vitro again, in bronchial cell cultures, we can easily show that it targets CFTR at the apical membrane here. Whereas in the control cells, you see here that CFTR remains in the cytoplasm and is then targeted for degradation. However, in vitro studies, the results only showed that this drug, intubation with this drug, only restored 15% of the function and demonstrated a sort of ceiling effect for restoration in CFTR function. And indeed, in the phase 2 studies with only Ivacaftor, the results were really disappointing. Patients were not improved by taking only Ivacaftor. Whereas when you associate Ivacaftor correcting the protein expression targeting CFTR mutated delta F508 at the membrane, but associating Ivacaftor to potentiate, to open the gate. Indeed, in vitro study, you really see that you have an improvement above 20% of CFTR function, and when you add Ivacaftor and Ivacaftor, indeed, in a phase 2 study, you improve the function by more than 5% of FEV1. Whether this is really clinical beneficial, we don't know yet. There is now a huge phase 3 studies versus placebo, enrolling more than 1,000 patients all over the world, trying to demonstrate the beneficial effect of this synergy between the potentiator and the corrector. The last class of mutations is the defect in protein synthesis. Here, the defect is far more complex because this class includes nonsense mutation producing in-frame stop codon mutation, premature termination codon. And here, the goal is, of this suppression therapy is in fact to reduce the provability of the ribosome and to induce low levels of misreading of this premature termination codon. And if enough premature termination codon are coded into sense codon there, you might hope that you have a low amount but sufficient amount of normal CFTR functional protein to be clinically beneficial. That is the aim and the goal of this anti-nonsense suppression therapy. The main compounds which have been studied yet are gentamicin, the aminoglycosides, which is well known and used in daily clinical practice. But another drug very interesting is PTC184, atalorin, which is orally available and does not have the nephrotoxicity and ototoxicity of gentamicin. Phase 2 and phase 3 have been now done with atalorin in cystic fibrosis, but have very controversial effect. And now we are beginning again a second phase 3 study to confirm potential beneficial effect on respiratory function with atalorin in cystic fibrosis patients. But obviously, you can see here that this anti-nonsense therapy, a no-nonsense drug, as nature said, is obviously a novel approach that has that may lead to outstanding results far beyond the field of cystic fibrosis, because disease due to nonsense mutations, stop codon mutations, are also many other disease, genetic disease, and also a big part of also some cancers in cancer biogenesis. So this might be a novel approach far beyond the field of cystic fibrosis. So how far are we from our goal? How can we approach the goal to treat and to address all cystic fibrosis causing mutations? If we evaluate the mutations which can be improved by Ivacaftor, accounts for more than 7% mutations. Delta F508 is more than 90% mutations in the Caucasian populations. So we can treat by more than 90% of the mutations now in cystic fibrosis patients. However, this dream to cure for cystic fibrosis is maybe not so far, but we have to solve many other issues because, as I said here, to correct this mutation, we don't have for the moment sufficient results. And finally, we have also to face patients with end-stage disease, as Nicolas, he claimed to die because he had no life, he said last year. And indeed, in these patients, we have to focus on quality of life. So that is palliative care. These patients have a really high burden of treatment, including non-invasive ventilation, gastrostomy to improve nutritional status, chronic IV course with antibiotics. They also suffer of chronic, long-lasting recurrent pain. We made a study with the adult group and demonstrated that far more than 70% of patients reported episodes of pains and chronic pains. And this may be due because, as one of patients said, patient is reassuring. They didn't claim for treatment. They only said that my body is in tatters, it's breaking up, doctors can patch it up, and my body is moving towards the end. And finally, for this patient, we can propose lung transplant, but we have to be very humble because the long-term survival for lung transplantation now remains very unsatisfactory, with 5 years and survival marginally greater than 50%. So we have to balance between the indications of lung transplant and also the possibility to survive with this end-stage disease. And finally, to conclude or to open the discussion, I want to illustrate this dilemma by a last observation, which illustrates how it is difficult to go from palliative to curative care. Marion is 17 years old when I meet her. She has a very severe disease and we want to implement a transplant project and all what it involves medically. Non-invasive ventilation, gastrostomy, chronic IV antibiotic course. Finally, in May, 5 months after the proposal, she says yes to the transplant, but waiting, as she says, for the right time. In August, she has a critical condition. We urge her, we have to transplant because otherwise we could not control the situations. She asked to write lectures for 2 days, then she asked to go back home for last weekend. And during this weekend, Marion ended her life writing that in any case, she had no other choice. She had to face a dilemma, and this dilemma between choosing to live with a second disease, lung transplant, or to die with her no life, CF disease, was too difficult for her. But the dilemma is also for the doctor. What were we supposed to do? To convince her to live with a second disease, lung transplant? To let her choose, to take the time, even if it's too late? To help her to take the decision. She said yes, not to disappoint, but we did not allow her to say no. We should have laid aside our desire to cure her. We should have helped take a break, and maybe she could have solved her dilemma. And finally, what I want to end is, I have no conclusion, finally, for this talk from cure to palliation. We have on the one hand a symptomatic care, which has considerably improved quality of life and survival of our patients. We have on the other hand a curative care, short-circuit mutations, keeping the patients asymptomatic. This is a dream, not real for the moment, but before reaching this, we have to solve new challenges, including long-term efficacy, long-term tolerance of these new compounds, and finally, as illustrated in all what I have intended to say, the finality of care for this patient has to be thought. And finally, I think that this finality of care would need to, in fact, be discussed between, the interaction of the clinical team again and the fundamental research. And finally, I want to end by acknowledging the wonderful people I'm working with, both in Necker Hospital and also in CERN with Alexander Edelman, and with the final aim to cure patients. Thank you very much.
Very much, Professor Sermet, for this fascinating presentation. It is open to the discussion. I would like to ask you, because with time we see more and more patients with midlife expectancy increase, with resistant Pseudomonas and also gram-negative bacteria. And we have a lack of efficient antibiotics, especially native antibiotics. What is your vision about this problem and the scientific research on this domain? Because it's probably a little domain, also not so interesting for the great companies of antibiotics.
Well, I wouldn't say that, because for sure we have most of our end-stage patients have multi-resistance strains, both Pseudomonas, but as we said, also gram-negative, including also anaerobic bacteria. But we have to consider not only the bacteria we isolate in the Petri box, but also the whole microbiome, which includes Streptococcus, anaerobic Prevotella. And I would say my experience is now, even when you treat with a long-lasting antibiotic, you might stabilize the disease. You might stabilize the disease because obviously you don't only target the bacteria you have in the Petri box as Pseudomonas, but also many other bacteria. And I would advise to use anti-anaerobic drugs such as tazocillin or augmentin. However, you are right. At one time, I should say in the window, you can't succeed anymore in stabilization. And that is for sure the window to go to the transplant indications. Not too early, because obviously, as I showed you, life expectancy after lung transplant is not such successful, but also not too late, because we can't transplant patients who are really exhausted and malnourished and in too bad status. And now a very emerging strategy for this multi-resistance bacteria is emerging from the phage therapy. There are several papers on this phage therapy. Phage are in fact virus infecting the bacteria and killing the bacteria. And so this phage might be targeted to the bacteria infecting the patients, and they might, at least transiently, be a successful process, at least in the mouse model. And they have been also developed for multi-resistance infections outside the field of CF. And there is now some attempts to develop that in the field of this multi-resistance bacteria in cystic fibrosis.
Other questions? If there is no other question, thank you still for your presentation. I will now introduce the next speaker.